Hi everyone, my name is Madison Hinkle-Dyer, and today we're going to be discussing evidence-based practice and ICU delirium. A little bit of an introduction. Delirium is a very prevalent and seriously hazardous component to patient safety, outcomes, and overall well-being, not just during their hospital stay, but also after discharge. As was stated, it is very prevalent. So about 60 to 80% of mechanically ventilated patients have experienced some form of delirium, at least one symptom of the behavioral disturbances, and 20 to 50% of those that are not mechanically ventilated have also experienced it as well, according to Brummel and Garrard in 2013. Brummel and Garrard in 2013 also found that presence of ICU delirium was associated with prolongation of mechanical ventilation. These patients also typically have inadvertent removal of lines, tubes, and dressings, and the need for physical or chemical restraints. Both of those are affiliated with the fact that patients are extremely restless and agitated when they're delirious. And so sometimes it's a serious patient safety issue, and they will require physical or chemical restraints. This also results in an increased length of stay and greater hospital expenses because now the hospital has to accommodate for this additional serious diagnosis and has to use massive resources in order to assist with the treatment. So the purpose of this presentation is to discuss the current issue of ICU delirium and the negative long-term effects it can have on patients. My rationale for choosing this project is because I currently work in the trauma neuro ICU. I also do have experience as a PTCA in the intermediate ICU, and in both places I've seen patients that have had long-term effects from delirium, multiple readmissions, inability to care for themselves at home, and I thought that this is a very serious issue, and I wanted to evaluate the research on it. That brings us over to our research question. So the research question I developed was, in adult intensive care unit populations, does the presence of delirium during hospitalization result in negative long-term effects after discharge? Breaking that down here, the population would be adults in the intensive care unit, so anybody greater than 18. Next, we have the presence of delirium during the hospitalization. This was not a comparison research question, so the C was not applicable. And then for outcomes, we have negative long-term effects. Which then brings us over into the literature search that was required. So searches were conducted through Google Scholar and Open Athens. The subject headings that I typically used were ICU and delirium, and I found over thousands of different articles in each search engine. I also used delirium and mortality and delirium and outcomes, and I was able to find quite a few different articles that met my criteria. So the relevant articles were chosen due to having multiple authors, typically ones that had some form of doctorate degree, and then they were all within the last 5 years, and they were all primary studies. To reflect on the research process, it was pretty frustrating because there was such a large volume that I had to go through. It took quite a lot of time, and then it was hard trying to determine what level of ICU, because you can put ICU or critical care and it would give every single possible option, and I didn't realize how many pediatric ICUs had the same issue as well, which does make sense, but I didn't really grasp how much research was conducted in those units as well, which continued to populate. And then additionally, with the volume of research, there were too many systematic reviews, which made it extremely challenging because as soon as I thought that I'd found the correct research article, it was a systematic review. And that brings us to our literature synthesis. So all of these studies were conducted in an ICU setting, although there were some that were in different subpopulations. There was one article that was conducted in a PACU associated surgical ICU. There was one in an HVICU, another in a medical surgical ICU, but all of them were conducted in the ICU setting and had adult patients, and in all of these studies, all of the patients' previous diagnoses and current, infections or sepsis, any possible rule-outs for delirium were all taken into account. So some similarities here were the studies conducted by Brummel in 2014, Abella in 2013, and Mangosan, Hooper, Denslow, and Travis in 2015 concluded that patients who experience ICU delirium typically face challenges following discharge, especially those including activities of daily living disabilities, dependency on others for physical care, which then would result in increased utilization of home health services. The study by Aliberti et al. In 2015 concluded that the presence of at least one of the symptoms of delirium, which is typically behavioral disturbances and cognitive dysfunction, was an independent predictor of mortality up to even 1 year after discharge. And this was quite similar to Brummel in 2014 and Abella in 2013, that they both concluded that the patient's experience of ICU delirium was resulted in an increased mortality after 6 months, which is 6 months after discharge and not even just 6 months out of coming out of the ICU, which is a pretty significant amount of time depending on these patients' comorbidities. Additionally, the study by Wolters in 2014 was the major contrast of all of these articles, and that it didn't agree with having the ICU delirium resulting in physical dependency or ADL disability. So, but all of the participants in that study were given a survey about a year after discharge from the hospital. And so one of the topics of the survey was to self-report cognitive functioning. And it was shown in this study that most of these patients reported to have mild to severe struggles with cognitive functioning even 1 year after discharge, which is quite an extreme amount of time for them to not be able to function on the cognitive level they did prior to admission. And while all these studies don't agree on the long-term consequences, they all do support a correlation between ICU delirium and the negative long-term patient outcomes, which was the goal for research in this project. A little reflection on the literature synthesis. It was a little challenging since, there isn't too much practice outside of this course alone. It was a little challenging to concisely summarize and analyze all of the articles and to make sure that I was actually linking all of the similarities I could and then identifying those contrasts. And there weren't too many contrasting articles, which would have been an interesting approach to look at, but I felt like most of the similarities that I did find were mildly different, but also related so that they could build upon each other. There is a practice recommendation that I would recommend here. There does for sure need to be interventions. The research here that we have supported does accentuate that there are changes that need to occur, and that prevention here is key. I personally do recommend initiation of a sleep promotion and delirium prevention bundles. I am the chair, the delirium champion for the A through F bundle at Lancaster General Hospital. And while we don't necessarily have a sleep promotion bundle, after doing the research here, I am personally going to talk with our committee and see if we can actually get something involved. So in order to support that, there was a study conducted by Patel, Baldwin, Bunting, and Leha in 2014 that does support that the introduction of a bundle of non-pharmacological methods to prevent ICU delirium, including, decrease in environmental noise and light reduction, trying to help promote a natural circadian rhythm. It does allow for reduction in sleep deprivation, not necessarily optimal sleep because it is still in ICU, which is quite a challenge, but it does also decrease the presence of delirium. Another study that was conducted by Kamdar in 2013 suggests that decreasing sleep disruptions, dimming lights, and promoting normal circadian rhythms in the ICU does result in improved sleep quality and the reduction in incidence of delirium. Of course, there are barriers to these recommendations, especially in the unit that I experience. There are some very serious challenges since most of these patients do have neuro complications, so their clinical condition may not warrant minimal sleep interruptions as my first barrier. Patients that typically have a head injury or any form of spinal injury will be a hourly neuro assessment, which definitely puts on a challenge when trying to prevent these patients from having ICU delirium. The second barrier is the external environment can't necessarily be manipulated. For example, in the ICUs, people, have changes in clinical status, and I can't guarantee that my patient next, to the room that, they're intubating or there is a code, I can't guarantee that that patient's going to be able to get any sleep that night because of the environment. And even with closing the door and closing the curtain, the hospital setting is quite loud, especially during these situations. And the third barrier I have is patient safety risk factors. So many of these patients that do experience delirium require a cognitive coach if they do not have any form of restraint, which is typically what people would hope for, having somebody in there at bedside so that we have to avoid any serious interventions that would ultimately harm the patient. And these safety risk factors is that typically patients that are delirious have all of these behavioral disturbances that they usually don't experience, and so they're very restless. They want to get out of bed. They're pulling things off of themselves. So we need to have somebody at bedside with them, which isn't always possible, and we can't always, close the doors and let them rest before they even experience a delirium, because there are those that will forget that they have all of these wires attached and will try to get out of bed, and then with a closed door, it makes it harder to get in quickly to assist that patient before they end up on the floor. So in conclusion here, it's very evident that research does support that ICU delirium can have very serious long-term detrimental effects, including the ADL disabilities and mortality, from 6 months to a year after discharge. Prevention and prompt treatment is absolutely key here. So we need to have more interventions to prevent them, and we do have to have more accurate nursing assessments. Like I said previously, I'm the delirium champion, and I go around and I help assist people so that they understand the CAM ICUs. It's clear that not many people do, but we definitely need to be educating ourselves so that we can promote proper interventions and help these patients and ultimately prevent ICU delirium. Thank you guys for listening, and I look forward to reading all of your presentations.